who knows the case?
I was in the.
So you know the case. Okay, so tell us, let's go through it.
Yeah.
So you have a CT angio.
Yeah. CT angiogram.
Sure.
Oh, CT angiogram. Can I window it a little bit?
Yeah, you want to try?
Sure.
Sorry, I'm sitting in the seat.
It's already too late for that.
I make sure I'll take that off of the video.
You heard.
Okay, so CT angiogram. This is already
There might be some thin sections of the
yeah.
neck.
Yes. So one thing we noticed here, or soon we notice it.
So what, you got too many vessels down in these?
Yeah, so this is higher neck, ICA is asymmetric, thread-like ICA on the right side, vertebral, okay.
So when you're trying to figure out if there's a carotid canal, what are you trying to do?
I'm trying to see if this ICA stenosis has been something chronic, which means that the carotid canal also is different in size, which it is.
In the carotid artery?
Yes.
Okay, so that's a very good example. So you have one big foramen and one small foramen. Does that tell you anything?
Yes, so this the artery on the left side has had 30 years to carve the bone, but on the right side it had carved a smaller hole.
Okay, what does that mean? You're trying to determine if there is a stenosis, or you determine if there is a, you're born this way.
Yes.
Okay? So when you have the bone, it's the best way. So, the bone is big, but the vessel is small, that means it's an acquired condition. Make sense?
Yes.
The bone is the right size when it was developed, and then something happened. But if the bone is small, that means it's hypoplastic. If there is no foramina, there is a genesis, right? Okay, so what do you think is going on here?
So it has been probably congenital hypoplasia.
Correct. So leave that there, and let's go in the middle. Let's see your angiogram.
Sure.
So that's the reason we did the angio, is because we thought there was a...
And no, actually, there was something higher up.
Okay, because I saw a lot of red, yeah, okay. So you can change the thing. If you want two big screens, if you
So, and then higher up, there was this discussion of, and then you see a change in the IC diameter and the cavernous segment.
but there is a cavernous carotid, right?
Uh,
So how we have to figure out how it feels.
yes. And then higher up in the right temporal, there was suspicion of AVM. And there's hypervascularity here. But, yeah, so that was the reason.
So the reason of the angiogram was
Was
rule out an AVM.
AVM in the right temporal region.
Mhm. And also the deep venous system, you have something. Okay. How old is the kid?
30.
30. Big calcification in the falls. Right. You don't think there's a meningioma there? Okay, so we've seen enough of this back and forth, back and forth. Show me in geography. You can, it's okay to leave it there. Well, doesn't matter, go. So you're in radial.
Try to select a right verb. So this is a right verb in injection reflux.
Okay, so leave that there, put the lateral on the. Okay. So what can you tell me?
So I can see the main vessels of the system.
Okay, so go from the beginning. Go from you got a picture in front. Come, sit over here now. So let's try to. We're faced with something in front of our eyes, and we need to be able to tell every single line here what it is or who she is, right? Okay, so we're gonna come here down below here. Could you tell me anything about this?
So this is probably muscular branch. It is before the.
Remember that the arteries follow the nerves. The muscles happen to be there. They're not really muscular. That's a big mistake. Of course they're in the muscle, but there is spaces. This machine unfortunately cannot give you bone, but we'll get to it. Okay, so there is a branch here, right?
You might have native there too.
Well, yeah, we do as much as we can, and we can see it on the other view, right? Could be this one, this similar caliber, right? There is another artery, there's another vessel here, there's another vessel here, right? There's another vessel here, there's another vessel here. Could we tell who they are on? Each one of them. This one here.
Yeah, this one is probably a branch leading to anterior spinal. From where?
No, you said anterior spinal?
It's going to form anterior spinal.
Well, could be, but anterior spinal would be more at where the two verts ideally would be here, or here, or here. So this would be two possibilities. There is a spinal cord artery, or there is a bony artery. It's called the odontoid process from the ascending pharyngeal. So we come here, and actually we see the odontoid process here. But we also see this and this. So we're seeing more than in the AP. And it's important if you have both. Now, obviously this one is this one, right? Because I went back in the very early phase, right? Very early phase, right? So we're using the dynamic aspect of the angio. So we are quite sure that this one is this one. Agree?
Yeah.
And we know that this one is this one. Right?
Yeah.
So irrespective of the name, is how do we work it out? So we know. Now the next one is to see if this one, can I see, is it crossing? Okay, no, so it is originating from this vessel, which correlates with this. Okay? Now if I had the bone here, here is the posterior elements, here is the anterior elements. This patient is so good, he's behaving so good. Okay.
General anesthesia.
That's why. Okay, so it is the anterior spinal artery. It's a contribution that is going to anastomose. It's called the posterolateral, right? But this is anterior spinal. If it projects posterior to the vert, is one. If it projects anterior to the vert, is ascending pharyngeal. Okay, that's a good way to try to differentiate it. Definitely, this is what you call muscular, but in reality, is the occiput. There's the first space. Here's C1. Sorry, occiput, C1. This is C2. So it's at the second vertebral body. And what is the importance of that artery? C2 anastomosis what with what?
The occipital artery.
Occipital artery with what? Yes.
With the vertebral.
With the vertebra. And why is that important? Because when you're doing embolization of the occipital, you don't want to get a posterior fossa stroke, right? So that little bastard can be quite important. In addition, C2 and C3 will anastomose with the cervical arteries. And C3 will anastomose with the ascending pharyngeal. Sorry, okay, that's not the case. But you see, there's a lot of information that's good to use. It helps you. Okay, so then we come up here and we see interesting stuff here, right? There is this vessel going like this, and there is this one going like that. And this is just to show you the symmetry in the vascular system is not correct. We're not symmetric. So there is one arrangement in here, and there's a completely different arrangement here. Could you tell me the difference? Or could you tell, what do you think this one is?
So can we go before? I just want to see if I see anything off of lateral vert.
Well, I mean, when you see a vessel like this, you have two ways to go. You see from the origin and trace it back, or you go back and trace it back, right?
So I would think this is,
Where is it originating from?
it's distal, proximal basilar.
Proximal. And then there's another one here.
So we call that one pica, the first one ICA.
This is at the lower origin of pica, and this should be then
ICA.
ICA. And if I continue, it goes towards the auditory area, right? To the petrous bone. That's a way how I know anterior inferior cerebellar artery, right? Whereas here, there's a variant, which is actually quite interesting. And when I see this variant, which I can make it a pica, right? I cannot make it a pica ICA. Then I try to see in next collateral superior cerebellar, and you see there's also a discrepancy of the superior cerebellar artery, right? Because this has to compensate with more territory, because here is more dominant. So it's always a balance, and that's how we try to make it. Plus, he's got a peculiar thing at the basilar bifurcation, where the dominance occurred from this branch. So almost all, if not the main perforators that will go to the midbrain and so on, will come from the right B1. When you have a perfect T is more balanced, okay? So this is telling us that there was some kind of a, now I can predict a small PCOM here. And we'll see, because we have the MCA. Jeez. So I have very peculiar vessels to skip this, huh? So this one, I don't know what it is. It's coming, it's a perforator. It's not quite an ICA, but I don't know exactly. Yeah, let's go towards ICA territory. But look how the superior cerebellar here is taking over. Okay? Now the superior cerebellar will be more, the best way for it to do collateralization is through the cerebellum, this way. Whereas ICA, pica, will follow this parallel. This sometimes there's a network that goes craniocaudal. I forgot the name of it. We have it in the book, a variant like this. Okay, that's fascinating, huh? You see how we're trying to make territory here. Okay, let's see what else we find.
We're not even at the fascination point.
We haven't gotten there. Okay, and then you see also there's a dominance of this vertebral versus that vertebral. And okay, here is another spinal artery, I think. Yes, here is the other. Okay, so these two, if we were to have a lower down, I bet you this would come like a triangle to anastomose, because the spinal cord is open at the beginning, and then it fuses. So the anterior spinal artery can be duplicated, not infrequently, in the cervical region because of the fusion. And I bet you this is what happened down below. Okay, so we see the two PCOMs, they seem to be okay. Okay, and we don't see no AV shunting, right? We don't see any aneurysms. Did you do a 3D here, or just went kept on going?
We didn't 3D. I think we may have done a second view of that.
Okay. Okay, there was no abnormality biogen on the vert. You did another view. You did another run. Let's try to.
So you would say the right foot is dominant because of the way the VV junction has been positioned?
Once again, let me see if I can make this. Okay. So let's see. Let me see if I was able to coordinate it. Put this one here, and now they should be together. Ask me the question again.
So you say the right vert is dominant because of the BB junction?
No, it's just dominant here. This is the part that, the fusion when something went well. It's called the caudal. I forget the name. But the importance here is that this vessel would be the crucial one to put. If you're going to put a flow diverter or whatever, you have to be more concerned that this one can give you some perforator like ischemia.
Okay.
If you have to, you may not have choice. But if you want, let's say that you're deciding one side versus the other, this is more likely to give you trouble. So you did this other view.
Yeah.
Okay, we see this lateral spinal. Okay. Okay. So what? There's nothing here. Did you think this was something? No. See this little bump here? Okay. Go to next. So we go to the bifurcation. Okay, look at that. Fascinating.
And also shrunk the.
No, it's
The
fascinating.
canal.
So here we have a teeny weeny vessel, right? Okay, and a big vessel. So which one is the internal carotid? Which one is the external carotid?
Anatomically, the more posterior one. Physiologically, the more anterior one.
Wait. No. There's an internal carotid, there's an external carotid artery. Now the external carotid artery must be supplying the whole brain because they are through both. But it's not. So I need to get that one. There's a new one on me. Physiologically, anatomy. No, there is something happened here. Okay? There is a vessel that was a little bit larger, then becomes a teeny weeny thing. The question is now, this one, is it a dissection? Is this the ascending pharyngeal artery? Okay? Is this so-called the stapedial artery? And then we come into this one, and again, when you're faced with something like that, you go backwards, okay? And see one thing here, I see another one there. So this is the fascia. Now is this, look at this one, I would have taken a shot down below.
Yeah, and all of them have a lower
Origin, it's fascinating.
Come from like common.
So that's right. So look at this. This coming. Let me go. Okay. So this is lingua. Okay. This goes to the tongue. That's it. But very low origin. So now we're gonna have to figure out. Okay, what is what? There is a vessel back here. See this teeny weeny one?
Probably ascending pharyngeal.
It's the ascending pharyngeal. Yes. Okay, and then here is the main trunk of the.
We thought even STA has a lower.
Well, no, but here the ascending pharyngeal artery can originate from the internal carotid artery, or can originate from the bifurcation. It's known. And then look at this. This is definitely occipital artery. Look how low. Look how. You didn't get a shallow shot, huh? Oh, this would have been a beautiful. Okay, so now we have an interesting phenomena here. Okay, Christina, I'm after you this time. What is this structure?
That structure is the ICA.
Okay, not physiologic, but
Not
real.
physiologic.
How did it feel? How did it feel? What a nice case, guys. Even the palate has an abnormality. Okay, but we'll get to
Yeah.
Christina.
So it's getting collateral supply through
Of course, but
branches.
more. Collaterals doesn't mean from the, what is this one? And how do I identify it? The superficial temporal artery will always make, it comes from a deep position, and it's to go through the zygomat right here. So it comes deep position, and you can know this way you can find. So when you get this curve, I can identify. Remember, foramen spinoso helps me to identify the middle meningeal. This curve of the mandible helps me identify the superficial temporal.
Okay.
So if I have the superficial temporal here, oh, this is another. Look at it. It's beautiful. This case. Okay, so we have one structure here, we have one structure here. We have this. What is this? Anyone? Greg?
Artery foramen rotundum.
Foramen rotundum. Okay, remember, it always goes from anterior to posterior. Okay, so this is part of the ILT, inferior lateral trunk, right? So foramen rotundum. Then I have another artery here. We gotta have to figure out. Okay. So one could be the middle meningeal artery, or artery through or accessory meningeal artery, foramen ovale here probably, and so let's try to. Okay, so there is a lack of continuity here, and or there's a very small artery. We know from the CT that there was a stenosis, there was a low foramen, right?
Yes.
Okay, so we have to try to resolve. I think all this segment is being reconstituted this way and this way. See?
So only through the ILT not
Through part of the ILT.
median.
I mean, this is foramen rotundum, but there's another vessel that I can't give it a name. What's that?
Sorry, it's someone texting.
Okay, and then we have this, which is the concavity. This would be possibly part of middle meningeal and coming in towards the orbit. So it's a meningolacrima. Look at that. Do we have a picture of the head here? Next time you have something like that, take a picture down here and all that. I would have put the catheter right here and do a gentle injection because it will show you amazing stuff. Oof, this is really good. Okay, you see, fabulous, I figured it. So now I have this foramen rotundum and probably foramen ovale, and they are coming like that and reconstituting the carotid. Look, this carotid, but it's feeding backwards like this. And now that connects to this is the stump of what we saw here.
And that point of changing caliber is the foramen laceral? Or?
Yes, it's foramen laceral, correct. Gee, I've never seen a case like this. It's fantastic.
So the eye is being exclusively supplied by
Well, we have to find the ophthalmic. One second, this is a little more. I'm looking for the ophthalmic now because it's going to be coming out of this one. I have no ophthalmic here, right? There's no ophthalmic. Now the next question is: did something? This was a smaller artery, but did something happen here? No symptom, right?
well, the patient is developmentally.
Yeah, but no, they didn't get an acute stroke or didn't have apoptosis of an eye, a Horner syndrome, right?
Correct.
Okay, let me see what you did next. This is fascinating. Good, so now we have the head. Good, you did selective that vessel, so it's a network.
Although we selected
What you do it in room 3?
room 3.
Sorry. You can't resolve it. Oh, fascinating. There's the middle. Now, definitely, this is meningeal artery branches, right?
Yeah.
So we can trace it back. Now, if we go to the CAT scan, let's look for a foramen spinoso. Maybe there is no foramen spinoso. 1 second. There's the retinal blush, right?
Yes.
So then the ophthalmic artery is coming from here. Meningolacrimal.
And this meningolacrimal is a branch of MMA?
This is a very typical curve for meningolacrimal. Say, ask me the question again.
So this is a branch of MMA?
It's being supplied by, we can't resolve it that well here, but I think yes, I think it's middle meningeal artery. See, coming like this may be the area from foramen spinoso. What happened here? Where do I have this? Okay, sorry.
Last week you differentiated between middle meningeal and an accessory meningeal.
I'm having problems. I'm having little. This one, I mean, we know one thing. This is the real carotid artery. we have to, you know, guys, one of you should revisit, you know, go to the anatomy book, you know, from with Pierre, and look at the stapedial artery. The evolution of middle meningeal artery comes from the stapedial artery. So there's something went wrong here at that level. I don't recall. Maybe I should study it too. Okay, but definitely the way we're tracing is this is the internal carotid. We know that from the previous injection. And this internal carotid artery feels this way, downwards, right? Remember, it connected with that little string here. So if this is the carotid artery, then this probably is the accessory meningeal, which is anastomosis with rotundum. Rotundum, accessory meningeal, and middle meningeal form the three legs of the chicken, or the inferolateral trunk. But I can't resolve this area. See, there's some network, right? Look. So there might have been some hypoplasia, and then something happened, and collateral developed. I can't resolve it. But here is the one that's, this one is the one that goes to the eye, which is this one. Okay? We know that this is meningeal branches, and we will see them. Let's go forward. Yeah. So this meningeal arteries, right? We know that. Okay, let's do something else. Put this one here. And I'll put this one here, okay? So we have the lower and the upper, right? Break the link. So here we got, this is extra, right? We're not seeing it here, correct? This is the same. Okay, so there is something going back. Definitely superficial temporal arteries coming over here. You don't see that here, right? There's no superficial temporal.
It has a very low origin.
Yeah, but what I'm saying is that, again, we're trying, this is not distorted, it's a variation of anatomy. So we're trying to reconstruct it. So we're going backwards. I'm convinced that this helped me identify that it was superficial temporal. This helped me confirm it. Correct? You know, this what we know is rotundum, but there's one more. Rotundum is one. We got one extra one. So you know, the anatomy doesn't necessarily follow what we wanted, but we know one thing, that is coming from this thing. This is where this is coming. We also know this is the internal maxillary, and the internal maxillary belongs to the carotid embryologically. It is recruited then by the mandibular branch. So here something also happened at that period. Okay, we know this is the carotid or the continuation, right? And we know the ascending pharyngeal artery will give the artery foramen lacerum. So maybe this is what this is, and then reconstitute the carotid and reconstitute. That usually comes at C5. The foramen usually comes about this level. So this is coming through the carotid canal, which we know it's small, right? But it's existent. Okay, let's see the CAT scan. We have it. Okay, let's see the CAT scan. Let's see it with only windows. Let's see if we can see.
There should be better.
Not sure I can tell.
Is there a thin cuts?
Sorry?
Is there a thin cuts? Yeah, maybe this one is better.
Yeah.
Yeah, you're right. I think ascending pharyngeal comes up and then joins the carotid canal there, right?
Yes, I think that's.
Below.
We have a nice
Yeah,
sculpture
very
on
last one.
the left side. We know that this is an arrow. Let's see the difference here. But I'm trying to get more. Okay, we need a good head and neck radiologist to help us here.
What's up, honey? Yes, my dear.
We could ask Colin Daddy left, he's very good at this thing, to help us. This is good. This is wonderful, there's no. Okay. Well, good. Let's finish this and we'll call left and see if he can help us with. Okay, let's see what more we have. So you repeated this. Okay, this is much better quality. This definitely something. This is, I'm almost sure is the stapedial artery. You know, see if the book out of anatomy. I have the anatomy book. Greg, look on the bookshelf there. You can close my my luggage there. See if there's the volume 1 of anatomy. Okay, so look for the stapedial artery. Let's see if we can find something similar.
It's an old Control F.
Sorry?
It's an old Control F. So
For fine?
Back
Still
in
in
the
the,
day we had
the 20th century.
children forget about those.
Yeah, me too.
System orbital artery, stapedial artery. 267.
Table of contents.
267. See, there's something similar here. This is my case. So this is the so-called aberrant course of the carotid artery. Pharyngeal branch. See, here we have that pharyngeal branch. Let's see if we find something similar. Pierre used to collect all these rare, bizarre cases. Okay, so if we look at this, we should try to figure out, yeah, there's something like this. Okay, so who's going to research this and come back to us next week and give us a little, it's your case, right?
yes, it is.
Well, it's a way to learn, and you gotta teach me too, okay?
Sure. Yeah.
So I'm gonna lend you this, but you give it back to me. You have it?
Yes, I have.
Then why don't you, what are you laughing? You're gonna get back too, don't worry.
I have one.
Eh?
I have one too.
Okay, no, but seriously, because this can, in here, there's something, we're gonna be able to figure this one out.
So the question was the stapedial artery.
So please, yeah, you look for the stapedial, middle meningeal artery, stapedial artery. Okay, this is what, this, over here, this is where we're gonna find the secret of what happened, okay? Very good. Okay, so I have to learn too. What else we have? Let's see the other side. It's gonna be fast. Okay, so oh, you did do a lower injection.
We thought we have selected ascending pharyngeal, but
So this was just the occipital, right? You see now superficial temporal.
Yeah,
See, they have a common trunk
with
with the.
Vascular? I thought that.
Okay, let me just put this is the AP and this is the lateral. So this is the posterior auricular. This is muscle. And this is for sure muscle. So the question is, who's supplying the seventh nerve here? I'm glad you tried at least, so that means you were thinking. Who was your attending? John?
Dr. Fifi.
See, this definitely feels this way.
And those are branches of all IMAX.
Yeah, yes, yes. But this one, you know, here's the, some of it is a semipharyngeal here.
Helps me writing my report.
Yeah, this is
What?
like.
It also helps me writing my report.
Good, okay. So are you dictating the cases now?
Yeah.
Yeah, here's got a variation too. But you didn't find any, there's no IVM, anything like that.
No, there was, I think this is all collateral. We had a similar
Yeah, yeah, collateral.
case we thought as AVM of the spine, but patient was
Okay, what is this artery? What is
The
Christina?
same one artery of the foramen reclinum.
Yes. You're never going. I don't want you to ever forget it.
it's interesting. So
Do you know what this one is? What is this one?
That's on the maxillary.
Internal maxillary. Okay. So what is this one? Goes to the muscle.
Is that a deep
Mid deep temporal.
temporal? Yeah.
This is the anterior deep temporal. So between this and this is the temporalis muscle. Okay? And then this is descending palatine. And here there is a variation in the palate. Look how dominant the superior palatine artery is. Proof this kid is amazing. Also has a variation of the occipital.
Dr. Berenstein, sorry, a side question. So when you're choosing the safe embolization point for epistaxis,
For?
epistaxis.
Right.
So when you're passing, when you're going through IMAX, when we pass the inferior orbital, then everything beyond that should be safe, including.
It's safer, no, but the infraorbital still can give you a palpebral and go back there.
Yeah.
But it's also pressure of injection and size of particles. You know what I mean? For if you're doing epistaxis, to make it safe, you use particles that are about, you know, let's say 150 to 300 microns, and you just let the flow take them. You don't push them, because this is living structures. Although the vessel may be this small, if you push it too hard, you may. The limiting factor is the bone, but in the soft tissues, the vessels will have elasticity. Okay, Christina, what is this?
That's the superficial temporal.
And but what does this curve mean?
It's going over the zygoma.
See, it's getting there. Okay, let's see up here. So here we're missing the middle meningeal artery. And again, we have a difference with the ophthalmic. A small ophthalmic here, foramen rotundum, anterior deep temporal will go to lacrimal gland.
This anterior temporal gets
There's a variation in the venous system too. Can I Wow, this kid is a book. Sorry, let me just work it up in my mind. There's a small vessel. This could be venous, but that's why we couldn't find it on the other side. I used to know the bony foramina really well, CT really well, but I've done it in so many years. So why you repeat this one? Would be nice if you do selective each.
He wanted to get the IC out of shadow. There's a like midpoint stenosis. ICA.
There's another thing. Can you, Christina, tell me this branch? What it is? It's off the occipital. In the occipital, we want to find arteries that are cutaneous and arteries that go through the bone and supply the meninges, like a dural AVM, something like that. How do you differentiate it? What do you think this one? Is this superficial, skin, or is it meningeal bone?
I think it's skin just because of the tortuosity of the vessel.
appearance. Okay? It does come in around the muscle somehow here. Whereas this one is more of a meningeal artery. See, I have not resolved the meningeal supply to the dura. There's no vertebral on the left? Or head direct origin?
We thought that there is, but just lower. Yeah, there.
It is, great case. Okay, there's pica. We found pica. It's a very low origin, C2. This is pica. You see how the same, it follows parallels that, but this is pica. This is a low origin of pica. Okay, that's why this was so small. So we found the balance. Okay, same thing. Always try the circle of Willis's, sort of. And this kid is really, right?
Yeah, baby.
Great case. I'm going to keep it in there because I'm going to look at it for a little more. I'm trying now. We need to try to now figure out also the meninges still haven't resolved. Definitely this. This is a meningeal artery. It's a cutaneous artery too. And what is this one here?
Is the clival?
Well, yeah, but I'm having, I need to connect it somehow. I mean, I can see the wall. You see, I can see the wall of this artery, right? So it's not part of the internal carotid artery. I think it's the same one as this one. I'm not sure. Definitely, this is a foramen here. This case is very interesting. Okay, so this is posterior auricular. So this is a semipharyngeal. And what is this one here? Gee, did you see this case? Yeah.
Yeah, it's very interesting.
Very peculiar.
The
Okay,
next-
so you're gonna study and give us a,
Study.
you use this case to then fill it up, okay?
Thanks, Dr.
Thanks,
Good,
Dr.
thank
for
you
joining.
guys. It was great. It was a great case. Very good.